This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week I'm coming to you from KRMC's main campus. I'm at KRMC Palliative Care, and my guest is Dr. Karleen Adams. Dr. Adams, welcome back.
Thank you. I'm so excited to be here.
Thank you. I'm delighted to be here in your office. We compared notes. It's been 5 years since our first conversation.
Wow. Time goes so fast.
Went fast, and when we talked, we were doing the COVID thing. I don't think either of us wants to dwell on that.
No.
What a time that was, huh?
Crazy time. Yeah.
And you were just starting at that point, right?
Mm-hmm.
Your practice has grown and changed a lot in the course of those 5 years. We will be talking about palliative medicine, what it is. That's a good place to begin. We'll also be talking about your expanding role here at the hospital. So we have a lot to talk about.
Excellent.
Let's start with a definition. What is palliative medicine?
Well, palliative medicine has kind of, I say, two different, very distinct modalities, inpatient and outpatient. Inpatient, where I am now, we do a lot of goals of care discussions with patients that come in that are really in probably the last phases of their life that might be suffering from a lot of symptoms like pain, anxiety, shortness of breath, that we need to start sitting down and talking about what are their goals, what do they know about their disease process, and who is there to help them, have they done their advanced directives? We help with, saying, who's going to be your medical power of attorney? And if it comes to that point where you can't speak for yourself, what are the things that you would want done and not done? So that's what goals of care are. We also help manage their symptoms here when they're in the hospital, which is another big one. Outpatient is really focused on people that are still seeking aggressive medical treatment, going to see all of their specialists, their PCP, their oncologists, there are pulmonologists that are having a lot of symptoms from their disease that maybe their PCP or their pulmonologist don't feel quite comfortable managing. So we help with that and also maybe do their advanced directives and help them know what their choices are moving forward.
Palliative medicine as a whole deals with end-of-life care. When you meet with patients in an outpatient setting, are they, what do I want to say? Are there situations where they're not ready for that conversation? It's more the family that's trying to urge that, or how does that tend to go? For
outpatients, really, I've noticed more, we just started our outpatient, and actually we're only doing it 1 day a week, but for outpatient, it's more like they're there for symptom management. And we try to, bridge into that conversation of, do they understand what their prognosis is, what that disease course will look like, and have they thought about their choices, as gently as we can, because a lot of times, like you said, they're still seeking that aggressive medical treatment. They might not even be aware that they have a terminal illness, and even in the hospital. So in the hospital, it can be a very tough discussion that they're not ready for. Absolutely. And so I remember I've been saying this for years, so I'm sure we talked about this last time. I consider inpatient palliative as the Marines. We're the boots on the ground. We're on the front lines of that end-of-life care. And how aggressive do you go? At what point is it futile? At what point are you causing more harm? And if a family or a patient doesn't realize that they're at that stage in life and they don't realize that the things that they're being offered can be harmful, or they don't realize they have a choice, then I feel like we're really doing them a disservice. But at the same time, sometimes they don't want to have those conversations.
Right. Difficult conversations will be a theme of our conversation today.
Wonderful.
Well, that is a factor that's baked into almost everything I want to ask you, right? It's either closer to the top. Yeah, it's the nature of this line of work. We said you've been affiliated with KRMC for many years now, and you recently accepted a position as medical director with KRMC Hospice. So congratulations.
Thank you.
Yeah. And so what does that change mean for your practice? And more specifically, what does it mean for the patients?
That's a good question. So for the practice, it means more time, more involvement, absolutely. For the patients, I think it means a more continuity of care. So just like when you come to the hospital and maybe your kidneys start failing and they say, you know what, we want you to go see a nephrologist, your kidney doctor on the outside. Well, that's continuation of care. So you get out, you go see that doctor that saw you as an inpatient. Kind of the same thing. They come in and they're at the last phases of their life and they have decided that continuing aggressive medical treatment isn't in their best benefit and they choose KRMC Hospice, then I can continue to follow them through that transition.
Yeah. It's a point in their lives and it's a point for their families where there's so much else to think about. Right?
Absolutely.
And having to make a ton of phone calls and do a lot of arranging is just, it's so much more difficult in those circumstances.
Mm-hmm. And that's one of the things that, hospice focuses on is alleviating those stressors and doing the best that we can to make a person's end of life as comfortable as possible. And that's the whole person, not just their symptoms, but that their family, their caregivers, that they're getting the social support that they need as well. Is there things in the community that they could be receiving? FMLA paperwork, helping somebody get into a shower or giving a bed bath, all sorts of ways to alleviate the stress on a patient and their families is what hospice focuses on.
Dr. Adams, I want to ask you a potentially personal question, but I think it's okay.
Oh,
I think we've talked about what was it that drew you to this branch of medicine?
Oh my gosh, yeah, that's such a great question because it's hard to really understand how I got here. Definitely wasn't one of my top 3 things that I thought I was going to do when I was working to get into medical school or going through medical school. But I think the change happened for me when I was in my ICU rotations and I was just seeing so much futile treatment that did not change the outcome of that patient's, ending, except that they went through a lot of pain and suffering, and the families went through a lot of pain and suffering. But we had a strong palliative service and hospice service where I trained at. And when that palliative physician would come in and have the discussions with the families, and the families would, or the patients have this aha moment and transition to comfort care, there was so much relief in that. And I seen patients suffering that their suffering was taken care of and they had a peaceful passing instead of this, really traumatic passing. And I thought that was really beautiful. And it was something we were really missing in medicine. And it's not something that we talked about. I didn't learn about this until I was a residency in ICU, right? We were always taught, do more, do more, do more, do more, do everything you can. And God forbid we talk about death and dying. We don't want to upset the families. We don't want to upset the patients. Let's just keep being aggressive. And I was really also disheartened, I would say, by my clinical experiences in family medicine. I felt like I didn't have the time that I needed to really address what was ailing the patient, the bottom line, that I just didn't feel like giving them medication was really going to be what would help them, like they needed so much more than that. And my senior, one of my seniors actually went on to be the palliative director, and there was an opening in the fellowship, and she asked me to apply, probably because I was consulting her left and right. Please come see this patient. Please come see that patient. And she's like, I think you would do well at this. I had my doubts because both my parents had already passed, and they had passed, in a hospice situation, and I didn't think that I would be good at that death and dying stuff. But I did the rotation anyways. And the first part of it was at the hospice. And I was just really surprised how rewarding it was to help people in their last moments be comfortable as they transitioned out of this world, and how thankful people were. And although it was really hard, I guess the hardest things can also be the most rewarding things, where in family medicine, I felt like what you're doing was rewarding, but you didn't get instant gratification from it. It was you were doing things to help somebody for really, really long down the road, and you never know if it really worked or not. And sometimes, the people would leave and you never see them again. But in the hospice side, you saw immediately the comfort and the support you gave people, and families and patients were so grateful for it. So opening came up, she said, apply. And I said, okay, maybe I'll apply. What could it hurt? Get a little bit of extra experience. And now here I am, 11 years later, still doing nothing but palliative and hospice.
I'm imagining you as a young medical student, and they medical students show up and they're idealists and they're ready to save lives and prolong lives. And you saw such a need in terms of being able to care for folks at the end of their lives. That must have still, despite having seen that need, that must have required a cognitive shift for a medical student.
It was. I was a resident, and it was, and it was still, sometimes I still, I hope I'm doing the right thing, because it's so ingrained in you to do everything. And I feel like we just do such a terrible job of helping people pass. I really feel like I was called to it. I can't explain it in any other way. And it's definitely not something I wanted to do, but yet it just kept getting pushed towards it. And, and even sometimes here, especially during COVID, and I'm like, that's it. I can't do this anymore. It's so hard on the palliative side to be the bullet sponge, the target of the family or the patient's anger and their suffering. How could this be what are you saying to me? This isn't right, and you're the target for those emotions. And it's not you really, but they're taking it out on you, and so that can be so difficult.
Yeah.
But yet I can't seem to escape, because it just something else comes up and another opportunity comes up, and then there's I'm just stuck with it. But I do love it, and now that I get to be on the hospice side of it, I feel refreshed.
Yeah.
And okay, yes, it's all coming together. This need is here. It's very important, and it's very rewarding, although sometimes it breaks my heart. It's just how life is.
How do patients come to you?
Well, in the hospital, they have to have a consult. So either, the attending, the ER physician, the ICU physician has to consult us. When we have an outpatient clinic, it'll be a referral, just like somebody makes a referral to their cardiologist or nephrologist, which I'm hoping the outpatient, we're really working on it. We're really putting a lot of effort into it now. We're doing some things to bridge that. So I'm hoping that we're going to have that hopefully within the next 6 months or less is what I'm keeping my fingers crossed for.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week on the program, my guest is Dr. Karleen Adams. She's with KRMC Palliative Care, and she's also the medical director of KRMC Hospice. And Dr. Adams, when we talked about getting together for an interview, you said, I want to cover some of the common myths and misconceptions I hear all the time from families and patients entering hospice. Yes?
Yes, thank you. Yes, so One of the big misconceptions that I hear all the time is that I'm not ready to die, and when you go on hospice, they just give you a bunch of morphine until you die.
Yeah.
Huge misconception. I know where that comes from. I think it comes from when people go onto hospice, they often go on way too late in the progression of their disease, and they're not getting on until the very last moments of their life. And at that time, a physician should be treating their pain and shortness of breath and anxiety with opioids and benzos and things that, we just don't usually give out. And that can be perceived to the family members as, we're just giving these medications to cause the person to die. Right. In reality, the person is dying, and we're just giving just enough to make sure that they're not suffering. Right. But we're legally not allowed to give more to hasten their death, right? So that's a misconception. Another big misconception that they have is that hospice is a place that they go to. And hospice is not a place you go to, although they have inpatient units where you can go if you're having problems or use as a respite. But hospice is a service that comes to your home, just like home health does. I always like to tell my patients it's like home health on steroids. Mm-hmm. Like, you get a lot of help, a lot more help. You have a nurse who is not only on call 24/7, but comes to the house at least once or twice a week and make sure that the patient and their caregivers have what they need. They are on call, so if you, like, let's say a patient falls down and they can't get up, you can call your nurse instead of having to call EMS or somebody else, go to the hospital. And the nurse can arrange to either have somebody come and help you get up or, come there themselves and help a patient get up. Let's say they're having like a bout of nausea and vomiting. They can tell the caregivers, in your care package, you have these medications, give this and that. If that doesn't work, they will come and assist, right? So you always have this help available to you 24/7. Another thing is there's a CNA that can come to the house. They can help give somebody a bed bath or get them into a shower. They can come multiple times a week. This gives the patient so much dignity, especially if they're being cared for by like one of their children. Or maybe they have like an elderly spouse that can't help them with those kinds of things. There is this social worker who's there to make sure that all their affairs are in order, that whatever is available in the community, that they are eligible, they're getting FMLA paperwork, all those kind of social issues. Maybe they might need placement shortly, and they start looking into that and helping them find that placement. There's a chaplain who helps with spiritual needs, but I always recommend that people meet their chaplain, talk to their chaplain, because they're also highly educated in the grieving process. So even if somebody maybe not consider themselves religious or spiritual, that grieving support is so important. And then that team is overseen by a physician who is making, calling in for the DME equipment, which, by the way, they get beds, tables, commodes.
What does DME stand for?
Durable medical equipment.
Oh, okay. Yep.
So a lot of people, when they are on home health and things like that, they might be getting oxygen or a table and, a bed, a medical bed. But they're still like either renting these or paying a copay or something like that. But in hospice, all of that equipment is part of your service. It comes to you. You don't own it, but you're not renting it. You're not paying for it. The Medicare is paying for it. And when you no longer need it, the hospice comes and gets it and takes it, back and uses it for someone else in need. So it's an amazing benefit. And for Medicare, it's paid 100%. No co-fees, no penalties. And it's something that, you are not tied into. So if you go into it and you decide it's not for you, you can go out of it. You can always come back to the hospital if you want to stop. But it's important that people realize that hospice is a service for people who want to be at home, that want to focus on their comfort, focus on their quality of life, not necessarily the quantity of their life, and are not going to be coming back to the hospital and not going to want to be seeking more treatment from their oncologist or things like that.
But another common misconception you run into is, well, if the patient goes on hospice care, that means the patient's giving up. The patient will be gone any day now.
Right. Mm-hmm. And that's another misconception, big one. Thank you for bringing that up, TG, because that is not always the case. In fact, there's a lot of literature out there that has shown that sometimes when people get on hospice sooner than later, they can live longer because they're not seeking these aggressive medical treatments that have side effects, right? And sometimes these side effects can be detrimental to a patient, end their life prematurely. We know that a lot of cancer treatments can prematurely end people's life. We know that a lot of surgeries can cause complications to prematurely end people's life. Another thing is that if your symptoms are being managed, especially with things like end-stage heart failure, you're on oxygen, you're getting fluid overloaded. What do? We wait and wait and wait because we don't want to come to the emergency room. We can't get in to see our doctor because everybody is full and busy. And sometimes by the time we do something, it's gone too far, right? With hospice, the nurse will say, well, let's increase the Lasix. Let's get you a breathing treatment. Maybe you need an antibiotic. And that's the big misconception. People are like, no, you get no treatment. They stop everything. And they're just fill you full of morphine and you die. So I like to say sometimes you're not giving up, you're focusing, you're switching your focus to wanting to be treated for your comfort, right? You're still getting medical treatment, but now it's just focusing on your symptoms, focusing on your stressors, focusing on the quality of your life.
It's a personal decision, but I'm just thinking if I knew I were in the last year or so of my life, I would not want to go to too many appointments.
Absolutely.
I wouldn't be at the top of my list.
Right, exactly. And it's just really it's pretty sad to me that there's all these misconceptions out there because people really could be, missing out on some wonderful times in their life that they're spending, in a hospital or in their doctor's offices, and nobody wants to talk about this, and I hesitate to even say it, but these things are also costly, and sometimes they spend, their children's inheritance or leave their spouses with very significant financial burdens, where it really didn't change the outcome. There was a lot of suffering involved, and it's really, I think, stems from the fact that they don't understand that they have this option, and if they understand they have the option, they don't really understand the option. So I will say that what a palliative specialist can do that, like a lot of outpatient specialists aren't doing, is that we're not afraid to treat pain and shortness of breath with things that have become stigmatized as being bad, like opioids and benzodiazepines. And they can be very harmful. I understand that, especially when used in the wrong context. But they're also pretty much miracle drugs when you're talking about things like shortness of breath and anxiety and pain, and especially when somebody is entering into the last phases of their lives. Really, the gold standard used to be, before opioids were so demonized, is that when a patient went into a situation where their shortness of breath was no longer being controlled by oxygen, opioids are what people went on because they do such an amazing job of taking away that feeling that a patient is short of breath. And now I'm just seeing that is just, the doctors just aren't doing it anymore. And a palliative physician's not afraid to do that.
We foreshadowed a bit about the difficult conversations. So, Dr. Adams, here's a difficult conversation.
I thought I was going to get away with this one.
You're not getting. Let's talk about MAID. That is medical aid in dying. This is currently legal in Canada and many European countries. It's legal in 12 U.S. states, with 2 more coming this year. It's not legal in Arizona, but this year the Arizona House and Senate are looking at bills that would allow medical aid in dying. So the laws vary from place to place, but they do require generally that a patient should have a terminal or incurable illness or disability, should be of sound mind, cannot be coerced, must voluntarily and repeatedly express a wish to end his or her life, and must voluntarily take the specified lethal dose. So let me ask a naive question.
Okay.
Why is MAID so controversial?
Ooh, boy, that's a good question. You know, I believe that any type of right to die, MAID or physician assisted suicide, which is people are getting away from that term.
Yep.
But it does have an underlining tone of suicide, right? And in our culture, suicide is wrong for many reasons. And so that's why I think it is so controversial. From the hospice palliative side, we believe that if we can control people's symptoms, help with their stressors, that they're going to want to stick around for as long as possible. But I will say that in my 11 years of doing this, I have come across only a handful of people that I thought would have benefited if we could have hastened their dying process. So now, how do I feel about people making that choice? If they have the choice to end their life prematurely, if they have a terminal illness, that's a loaded question. I'm not sure. Yeah. And if I were involved in it, so I've never been involved in it, and as we had talked about just now, I have never in my career given a lethal dose of anything. I've always been very judicious about how much I give, watching the signs, watching the respirations, and stopping when a patient no longer needs it. And so I'm not sure how I would feel about writing a prescription for somebody to pass. It would have to be very special circumstances for sure, and yes, I would want them to be alert and oriented and have that. I know they're talking about having that psych consult to make sure that they are mentally not suicidal, things like that. This question, it would take a lot of unpacking, and I could see this being, it's a tough one.
Well, it's interesting. If you just followed news on this sort of subject, you would think that this comes up all the time. But as you just said, in all your years of practice in this field, it's only been a conversation maybe a few times.
Yes.
You, right?
And it's actually another thing that I just thought of is that people already think that hospice is a place that they go to and they, people get overdosed on morphine, right? Yeah. So if MAID were to be passed and that this became an option for people, I feel like they would be even more confused about what hospice provides. Like, oh no, I'm just going to go there and they're just going to kill me, and it's not true. So, like I said, I have seen very few times where I felt like, yes, this person would benefit from the option. But to be honest, TG, those people were not alert and oriented. They were pretty much out of it and suffering.
The real thing is that you're able to manage the symptoms in the vast majority of cases, and that's why that doesn't come up so often, right?
Right, exactly.
Well, Dr. Adams, you are a DO, that's a doctor of osteopathic medicine. But given the nature of this work, I'm guessing that counseling must be some significant aspect of what you do.
Absolutely.
Yeah. Tell me about it. We're sitting on the comfy chairs, so tell me about it.
We specialize in having the long conversations about what's happening, why it's happening, what the future looks like, and what those choices are. So I guess you can call that counseling. We understand that there's a lot of stressors and there's a lot of emotions involved, and in that a lot of times we're going to bear the brunt of that. And we've been trained to provide supportive listening and just hear a family or a patient out because they've been through a lot and they haven't had that opportunity to tell their story because everybody's so busy. It's kind of in and out. Hello, what's your ailment? Here's what I'm going to do. See you next week, and bye. So I guess when we provide counseling, we're really providing supportive listening, trying to find out what the stressors are, trying to find out what their needs are, and doing what we can to support them in that, whether it be helping them with their symptoms or helping them decide who their medical power of attorney is, helping them decide how far they want to go with their medical treatments, and then just being that sounding board.
Just this morning, I did an interview with your colleague, Stormy Beckerly. She is the bereavement counselor over at the Joan and Diana Hospice Home. And I asked her this question. I'm going to ask you the same question. Excuse me. My setup is that I love interviewing experts because I get free consultations. So. But here's the story. And this is a serious one. But I have a friend whose father-in-law is in poor health. And it seems that half the family understands that this gentleman is nearing the end of his life. The other half is not ready, and they're angry, and they're in denial. And every time there's a setback or some development, they respond with anger and blame and denial. Just the other day, my friend said, it looks like I have to get a lawyer. I don't know the whole details of that, but it has to do with power of attorney and just all of this stuff. He and his wife, they're really trying to do the right thing, do the best thing, and the other half of the family they don't see it the same way. Let's just say that, right? Is this sort of thing common? Do you see a lot of this?
Absolutely. Absolutely. This is one of the biggest reasons why we focus so much of our effort on trying to get patients to fill out their advance directives, to have their medical power of attorney, because there is this challenge with family members. It's really important that I believe anybody over the age of 50 should be having conversations with their families like, this is what I would want if I were in a situation A, B, or C. This is who I'd want to make medical decisions for me, and get that documented so you avoid these types of problems. Everybody handles end of life and death and dying differently, and there are the stages of grieving. And sometimes those stages of grieving can destroy families. If somebody is like, well, I've accepted this and this is what mom wants or dad wants, and somebody else is like, well, I haven't accepted this and I am angry and there is more we can do and I'm not going to give up and I'm going to keep fighting, and those two clash, then it can irreversibly damage that relationship, and those families can be torn apart. But we find that if there's a document and the dad said, this is what I wanted, this is who I want to make medical decisions for me, then you can alleviate that, not even bring it into the picture. Or if there is some of that, at least it's like, well, this is what Dad wanted.
That should be the deciding factor.
Mm-hmm.
So although it's often an uncomfortable conversation, the key is really have that conversation sooner than later.
Mm-hmm. Yeah, right. And, we do try to do community outreaches. We try to go to the health fairs so that we can be there to say, here's an advance directive, look at it, would you like to fill it out now? They're really pretty simple documents. Sometimes it takes less than 10, 15 minutes to complete. Yeah. You don't necessarily have to have them notarized, although your bank can notarize them for you. You just have to have a witness in most cases. I want to say this, though. People think that because they've signed this document that it just magically appears everywhere. If they have a document like this, they need to bring it to the hospital. They need to give copies to their providers, and their medical powers of attorney need to have copies and bring it with them should they ever go to a hospital or, accompany them to their doctor's offices. We can upload these things to the state, but even at that level, it's hard to navigate that, and a lot of people don't know how to navigate that. Yeah. So
it would be similar guidance for a DNR, a do not resuscitate order. You want to make sure people know that, right? You
absolutely.
have to advocate for yourself and for your family member if that's the decision that someone has made.
Right. And that's what, these advance directives, there is a part in there, it's called the living will. I wish they could call it something different because people hear will and they think it has to do with finances and who gets what. It has nothing to do with that. It only has to do with if you're in a state of mind that you cannot speak for yourself, but you're still alive. My will would be, continue all aggressive medical treatment until my body gives up, or let me be comfortable. Don't do CPR. Don't put in feeding tubes and things like that. And so that's what that living will addresses. That is the most important part of that document. That's what helps with families coming to terms with what their loved one would have wanted. And it's interesting, I'm thinking about this as I say that, is that there's been polls out there that, people say, how aggressive would you want to be at the end of your life? Would you want to be placed on machines and, hooked up to feeding tubes, and have your body sustained until it couldn't be sustained anymore? Or would you prefer to be at home and have a peaceful passing? Well, like 7 to 9 out of 10, depending on which study you look at, say, what would you say, TJ?
Well, I feel like I need to know the circumstances. I'm not. I have a few good years left in me, but right. Yeah, absolutely, right. If I had some awful accident, or suddenly got diagnosed with something that left me very sickly, and I'm super active. I have a hard time. I had knee surgery in December, and I had the worst time holding still for 5 days.
Uh-huh.
I mean, I was going crazy, right? Mm-hmm. So yeah, it would be very hard for me to stare at the ceiling week after week, month after month, while I got continually weaker and sicker. Yeah, it'd be very hard.
Right. And this advance directive is saying you have a terminal illness. You're in a vegetative state. You're irreversible, right? It's in a state where you can't make medical decisions for yourself.
Right.
So imagine if you're in that state, right? What would you want, right? 7 out of 10 people say, I would want to be comfortable. I would not want to be sustained on machines, right? But if you turn it around and you ask their loved ones while they're in the ICU, they're on a ventilator now, and then they can't make medical decisions for themselves, and we're seeing that this is, pretty much terminal and irreversible, and we're having conversations with family members. Hey, this is bad. This is how it's looking. What would your loved one want? And it's just the opposite. They're like, they would want everything. And I don't know if that's because, I think I know that part of that is because they don't want to be the ones to make that terrible decision, right? And so it's easier to say, continue to do everything, because I don't want to pull the plug. Right. I don't want to be the one to say, let them go.
Especially if there's some division in the family about that, right? I think for your example, I think my wife knows verbally my wishes in that kind of situation. I don't have that committed to writing. So then if some other part of the family came forward and said, oh no, that's not what he would want, right? Then there you go. There's the mess.
Right.
And then
and people have very strong opinions about, letting people die.
Yeah.
Some people feel like absolutely not. You have to do everything that you possibly can.
I'm listening to what it takes, I'm just thinking about what it must take to practice this branch of medicine. On one hand, yes, it's compassion, it's mercy, it's wanting these people to be able to pass with dignity. But also you have to have a lot of courage, because you're going up against, like, whether you like it or not, you're going to find yourself dealing with a lot of people's very strongly held principles, can we say?
Absolutely. And it's on all ends. It's on provider side, specialist sides, the patient, the family members. There's a lot of beliefs amongst medical providers that we do everything. So that's a battle in itself.
Well, given those battles, if today you met a young doc who said, I feel a calling toward palliative care, what kind of advice would you offer?
Run. No, I would be like, oh, thank God, please come help. I would be like, it's like I said before, it's very rewarding, but, I hope you're a fighter, because you're going to have some challenges.
How do you deal with the stresses?
I like dirt bikes. Yeah, I like to do things that are kind of aggressive.
So you like hobbies that could land you in the hospital?
Yes, it's weird. No, I like things that require me to be extremely mindful in what it is I'm doing. So for a few years when I was in residency, I was into climbing. And I hate heights. I have a fear of heights. And here I am climbing, rock walls and stuff. And then, but I always had an affinity towards dirt bikes. Ever since I was a little girl, we had dirt bikes. And so I found a club here, and I got back into dirt biking kind of through COVID, because, like COVID.
Oh, you had plenty of time.
Yeah, I didn't have any time.
You did. I'm sorry.
But it was like everything had to be outdoors,
That's right.
and dirt biking was the perfect COVID, get together, because you've got this helmet on. You're like, you're on your dirt bike. They're on their dirt bike.
Yeah.
So nobody was really spreading any diseases, except, probably getting, valley fever from all the dust that we're breathing in. But, when I'm on my bike, it is a complete mindful experience. I cannot think of anything else except what is ahead of me, how I'm going to get over this obstacle. And when I'm done, all my cortisol has been left up, and I'm just so relaxed and relieved and tired and sore. And I love it.
We've made it through the list. Is there anything that you is there anything I've missed or that you'd like to make sure we get in?
I just want to really try to get across to people to get their advanced directives done sooner than later. And, reach out to their PCP. If they're here in the hospital, they can request a consult, and we'll come and talk to them about that kind of stuff. If they have a lawyer, get it in writing, and then make sure that everybody that it needs to have one has one, especially their medical providers, and especially if they come to the hospital. I think that would solve a lot of problems. I can't tell you how many times we've gone up to the ICU with an individual who is literally dying on a mechanical ventilation, unable to speak with us. They've been here many, many times, and we have no one to call. We don't know who to notify, who's going to make medical decisions for them. And it's traumatizing to the patient. It's traumatizing to the medical team. So in closing, I would really, if I had one thing I wanted to say to the world, was please get your advance directives done. Please do your medical power of attorney. Please have those conversations.
That is Dr. Karleen Adams of KRMC Palliative Care. She is the medical director of KRMC Hospice. Dr. Adams, thank you so much for your time today.
Oh, TG, thank you. I really appreciate this opportunity. Thank you so much for coming.
For more information on KRMC Palliative Care, please call 928-263-3176. That's 263-3176. I'm TG LaFredo. That is another edition of Focus on Your Health. Thanks so much for listening. We'll catch you next time.